So, welcome to the Independence Age Friday briefing. We know that before the pandemic, the UK was already a very unequal society and had relatively high levels of income inequality for a developed country. A popular government mantra used in the first months of the pandemic was that we're all in this together. But we know that certain communities were more in this than others and have suffered disproportionately because of the crisis. COVID has shone a spotlight on inequalities in education, in income, in work, health, and wealth. School closures disrupted the learning of poorer children, leading to lower attainment. Mental health worsened in women and younger adults. And repeated lockdowns made it more difficult for younger, less educated, and lower earning people to work. And strikingly, the gap between the richest and poorest has widened, with the top 10% of richest people in the country gaining an average of £50,000. Now that the worst of the pandemic is behind us, we have a real opportunity to focus on how to rebuild society in a way that works better for everyone. Today, Independence Age will discuss how the pandemic amplifies inequalities in society and what we can do going forward. Here to join us for the discussion are Debbie Abrahams, MP for Oldham East and Saddleworth, and also the chair of the All-Party Parliamentary Group on Health and All Policies, and Professor Sir Michael Marmot, who is the director of the UCL Institute of Health Equity and the UCL Department of Epidemiology and Public Health, and the author of a series of Marmot reports that have shed a light on inequalities in the UK and in many other countries. Now, before we begin our discussion, I want to make a very brief personal statement as I'm chairing today. And I'm doing this because I'm someone who's been working with colleagues in Ukraine, Belarus, and Russia over 3 decades. For the past 2 years, we in this group have been discussing the threat to health posed by a small, invisible to the naked eye virus. But there are other threats, and although it's not the topic of our work as a group, we can't ignore them. And we're now seeing the effects of another threat, with a hostile state causing death and misery for the people of Ukraine. So even though we're not discussing that today, I'm sure that for many of us, our thoughts are very much with friends, colleagues, and just the ordinary people of Ukraine who are suffering there. So with that, I'd like to go to Christina Pagel, who will give us the latest figures. Over to you, Christina.
Thank you, Martin. Right, so today, I'm going to be looking at prevalence of COVID in the UK, just a quick update on where we are with variants, hospitalizations and deaths, and then the latest long COVID report came out, which I think is just worth showing the main things, and then just a couple of slides on inequality to kind of motivate the discussion afterwards. So the prevalence of COVID, this is now coming from the ONS infection survey, which tests a random subsample of the population every week. So it doesn't depend on access to testing, it doesn't depend on symptoms. So it is kind of the gold standard. And what you can see is that after the kind of big Omicron peaks in December and January, all the nations are falling except for Scotland. And Scotland, the prevalence has been rising quite substantially over the last few weeks. And it's now over 5% of people in Scotland currently test positive for COVID. And that is quite different to everything else. And I don't know exactly why that is, but it's worth highlighting. It's also worth highlighting that every nation is still far, far higher in terms of prevalence than it's been at any stage to date in the pandemic. So it's certainly not the case that COVID has gone away anywhere. In England and Wales, it looks like it might be plateauing here. And then England prevalence is highest in the southwest, and the southwest is also the only region where it increased over the last week. Just looking in England by age, you can see that the big drops that we've seen over the last few years have been driven almost entirely by drops in children, probably because so many of them got infected in January. If we look at older people, prevalence hasn't really changed in the last month at all. And that is relevant because for many of these people, their boosters will now be waning and offering less protection against infection, although hopefully still good protection against hospitalization. On the rising BA2 Omicron subvariant, it is continuing to increase in every nation. It's about 80% of cases now in Northern Ireland. It's dominant in England. It's actually very likely to be dominant in Scotland. We just don't have the data up to that last week, but Scotland's been tracking them throughout. And it's likely to be dominant in Wales within days. The latest UK HSA report says that actually there's no difference in vaccine efficacy between BA1 and BA2. So BA1 is the variant that we had over December and January. That's good news, but we are seeing quite significant waning and more waning than we saw with Delta. So after about 4 months, protection against getting infected and having symptoms drops to about 40 to 50% even after your booster. And although protection against hospitalization remains high, it is dropping. So it's gone from 80 to 95% to 75 to 85%. So looking now at the number of people in hospital. So this is the population adjusted number of people in hospital for each nation. And you can see again that it's falling everywhere except Scotland. And so the increase in prevalence that we've seen in Scotland has come with an increase in the number of people in hospital with COVID. And we're also seeing very early signs that there's a slight increase in the number of people in mechanically ventilated beds, so in ICU with Scotland. So although the overall number is much, much lower than it has been, and that's obviously a good thing, there are now signs that actually that is starting to go up again. If we look at admissions in England, just in the very last couple of days, we have seen increases again. So it's kind of not quite clear where this trend is going, and it's something we have to keep an eye on. And it might be related to the fact, as I said, that prevalence in older adults in England hasn't actually been coming down, but boosters are waning. Looking at deaths, deaths with COVID are still coming down, which is good. The kind of Omicron peak is now, several weeks behind us. However, in Scotland, this has started going up again. And it's kind of worth noting that the increase in Scotland that we've seen in cases from the ONS data is actually mostly in adults, it's not in children. And it includes increases, reasonable increases in people over 60 years old. And that could be why we're seeing increased hospitalizations and increased deaths. For long COVID, ONS Infection Survey releases a report at the beginning of every month. It's just released the most recent report. And now is the first time we're going to have data that includes infections in December, which means it's the first time we can see the impact of the really big Omicron wave that we had in December, which actually hit mostly adults. It's mostly adults that got infected in December, and mostly people who've been vaccinated. So it's kind of the first time we're seeing a big wave and actually quite a highly vaccinated population. And what we can see is that the number of people reporting long COVID, this is at least 4 weeks of ongoing symptoms, has gone up, and it's gone up by quite a bit in the last month. And this probably does reflect the high number of infections we saw in December with Omicron. And if we look at the age breakdown of this, so these are the different age groups, and each of these bars is at a different month, and red is the most recent month, which includes December. And you can see that the big increases month on month were actually in people between 17 and 50. And that is exactly the population that had the biggest peaks for Omicron infection. Of people with long COVID, about a third of them say the persistent symptoms don't affect their life at all, which is good news. About half say it affects their life a little. But almost 300,000 are saying it affects their life a lot. So actually, it's not the case that long COVID doesn't matter. It is really affecting people's lives and limiting their ability to carry out the lives as they did before. And just to highlight as well, I think people were talking about this, that exposure to infection matters. We've seen quite big increases in reported long COVID in teaching, in social care and healthcare, hospitality, in transport and civil government. So places where you have a lot of exposure to getting infected have undoubtedly seen big increases. So just finally on inequalities, and this is just kind of showing kind of the main indicators by level of deprivation and ethnicity. So this is hospital admission rate per 100,000 people by deprivation in England. This is from March 2020 to November 2021. So it covers, most of the pandemic. It doesn't yet include the Omicron wave. But you can see that you've had far more hospital admissions in people who live in the most deprived areas versus the least deprived areas. And there's kind of quite a clear gradient. As you get to least deprived, you're less likely to need hospital. You see exactly the same thing for deaths, that there have been more than twice as many deaths in the most deprived, people living in the most deprived areas than the least deprived. And this is also translated over into big differences by ethnicity. This is hospitalization by ethnicity, and you can see we've had far higher rates of hospitalization in Black and Asian populations compared to white populations, and the same for mortality. So as Martin said, it's not a pandemic that has hit people equally. And just since I was talking about long COVID, it's also the case that long COVID is more prevalent in the more deprived populations. And undoubtedly, some of this is to do with the fact that people are more likely to work in roles where they get exposed to getting infected. And when it comes to vaccination, we're also in a situation where if the more deprived area you live in, the less likely you are to be vaccinated and the less likely you are to have received the booster. So just to summarize, ONS infection survey shows that the number of people with COVID is falling in England, Wales, and Northern Ireland, but it is rising in Scotland. And again, the number of people in hospital is falling everywhere except Scotland, but admissions in England have actually risen just in the last couple of days. Deaths are flat or declining everywhere apart from Scotland. Omicron is still increasing everywhere. It's dominant in Northern Ireland, England, very likely dominant in Scotland, and it'll probably be dominant in Wales by next week. And the inequalities in hospitalization, deaths, and vaccination have been stark the whole time and remain stark now, and I will end there.
Great, thank you very much indeed, Christina. So we're now going to go into the discussion, and just to remind everyone that the sessions that we're holding over the current series of weeks are on topics that we believe will be the ones that should be, some of the ones that should be feeding into the inquiry that the Prime Minister has announced. So I think we could maybe bear that in mind as we listen to the responses. So Michael, maybe I could start with you. And of course, we know that you've been warning us about the societal case, the strong case for tackling systemic inequalities for many years. And of course, what we saw during the pandemic is how those inequalities left many disadvantaged and vulnerable groups exposed. Where do you think we stand right now? Do you feel that Westminster is more sympathetic to the case that you have been making for so many years for tackling the root causes of health inequalities in this country?
I think Westminster is totally distracted. I don't think there is a, quote, Westminster. I wrote a little opinion piece on the Levelling Up white paper. And what I said in that, to the extent that that reflects Westminster, it illustrates what I'm saying. The first part, the analysis part that Andy Haldane presumably was responsible for, was excellent. 4 objectives for levelling up, 12 missions, brilliant, wonderful. I endorse them all. I read like one of my reports, only better. So just absolutely terrific. Then it comes to implementation. And I quote from the white paper, they quote the figure from Germany. When Germany, quote, leveled up by incorporating the former German Democratic Republic into the Federal Republic, they spent 2 trillion euros over 25 years. That's the equivalent of 70 billion pounds each year. In the white paper, it says the levelling up budget for the 4 years, 21 to 24, is 4.8 billion pounds, 1.2 billion a year, compared with 70. This is not serious. So when you ask me, where does Westminster stand? if you read the first part of the Levelling Up White Paper, Westminster is completely on board. Everything I've been talking about for the last several decades is all there in the Levelling Up White Paper, except any will to do anything about it. 1.2 billion. I mean, it's derisory, it's insulting. Now, if you say it's a taster, it's a way of getting started, fine. But what's the Chancellor saying? I'm going to cut taxes as soon as I get the opportunity. And I want to ask him, why are you going to cut taxes? Would you like the level of child poverty to go up? Would you like to cut further the per capita spending in education? Would you like to cut further the spending on adult social care? Would you like the NHS to be even less prepared to deal with a pandemic? Why are you going to cut taxes? What's your mission? Which of these objectives or of the 12 missions do you think you'll achieve by cutting taxes? So when you ask me, where is Westminster? You could read this piece of fiction called the Levelling Up White Paper and say they're completely on board. Then you could listen to the Chancellor and say he can't wait to gallop off in the opposite direction.
You're on mute.
Sorry, maybe it's even worse than that, because I was just wondering, Michael, if when you looked at the last budget, if you sensed any coherence in it. I mean, clearly there was tax cutting there, but there are other ways of getting money for levelling up, which would be through growth. But there seemed to be a lack of any coherent strategy for promoting growth either. It seemed to be a sort of mishmash of bits and pieces.
I think the problem has gone on for a long time. As you know, it's now 2 years ago, on the 25th of February 2020, just before the pandemic crashed upon us, I published the Marmot Review 10 years on. And what we documented there was that life expectancy increase had slowed dramatically, health inequalities had got bigger, and life expectancy for the poorest people had gone down. That's where we were pre-pandemic, a decade of policies, arguably, and this is not a randomized controlled experiment, but arguably a decade of policies of austerity had led to a failure of health to improve, an increase in inequalities, and health for the poorest people getting worse. That's where we were pre-pandemic. And then the real danger is that the pandemic makes all of that worse. In the initial stage, when the Chancellor said, whatever it takes, I thought, wow, he's seen the light. We're no longer being presented with austerity as a moral imperative, whatever it takes. The furlough scheme was a bit miserly, but it was better than not having it. Great. But now we're back to where we were, removing the upgrade to universal credit. The estimate is something like between 200,000 and 300,000 extra children will be put into poverty between Wednesday and Thursday. And I've been saying if he can do that between Wednesday and Thursday, between Thursday and Friday, he could take 500,000 children out of poverty. This is a policy decision to increase child poverty. That's a policy decision.
Indeed. Well, Zubaida and I are going to be sharing this discussion, so let me just pass over to Zubaida now. Thank you.
We could listen to Michael Marmot all day, couldn't we? Thank you so much, Michael. I want to sort of start off a bit where you left off around the gap between rhetoric and reality, especially with you, Debbie. You are an extraordinary person in the sense that you are both the MP of Oldham East and Saddleworth, and you're the chair of the APPG on health policies. And you're incredibly unusual because you have a public health background as an MP, which in the context of this pandemic, I think is fascinating in itself. But what I want to talk to you particularly about is, as a public health trained MP, how did you reconcile what was happening in your area, in your constituency of Oldham East and Saddleworth, with what was going on in the Westminster bubble? And in particular, do you think those vastly different experiences explain some of the way that the government handled the pandemic and some of the ways in which they overlooked the impact of their policies on disadvantaged and vulnerable groups?
So just to start off with saying I agree with everything that Michael has said. And so, Maida, you're absolutely right. In terms of my public health background and the work that I did on health inequalities before I became an MP, that's why I became an MP, because we need to focus upstream. We need to focus where policy is being developed. That's why I set up the APPG for health and all policies. How did I reconcile what was happening in certain parts? You mustn't forget that there are parts of London that are incredibly deprived as well, as Christine has been said in her presentation. It is deprived communities, and we don't have an amorphous or a homogeneous rather population across all constituencies. But for me, it was more of the same. And as Michael has said in his, for example, in his 2020 review of COVID, it was because of the existing structural inequalities that we have seen this really exposed and exacerbated through COVID. So the Northwest as a whole, as we know, has been particularly badly affected. If you look at GDP output, if you look at salary levels and so on. If you look at my constituency, which is quite a contrast, I've got a very affluent part in Saddleworth, but a very poor part in Oldham East. It's absolutely clear why we had the high infection rates, why we had a higher level of hospitalisation and mortality. So it was more of the same. So I don't think that there's a uniform understanding, first of all, in terms of what health inequalities is, what causes it, and certainly in terms of the pandemic, how it relates to that. I really don't think that it's well understood across with parliamentarians. It may be in terms of civil servants better, but certainly not in terms of parliamentarians. However, our leaders, because I asked this time last year to our Prime Minister, and I don't want this to be political, but we need to be absolutely clear of where there is culpability here. I asked, would the Prime Minister be enacting all of Michael's recommendations from his review, which was showing about the high and unequal COVID death toll? It's absolutely, we support it. We recognise that we will be doing, but again, the proof is in the eating. Subsequent spring statements, budgets, and so on. We've got another one later on this month. Is in how that investment will follow the so-called agreement and understanding about what levelling up, what inequality really is, and what drives it. And as Michael again has said, I'm sorry to use it, but these are political choices. Inequality is not inevitable, and people, we really need to be trying to work not just with policymakers, but also with the public about this understanding. I think that is really where the government will feel under pressure if there's more of a public understanding about that this is just intolerable. We cannot allow this to go on.
Yeah,
sorry,
can I say that?
Long-winded.
No, not at all. At all. You've actually touched on quite a lot of important points there. Just extremely quickly, can I just take up this point that you were saying that Westminster didn't have this understanding about all the issues, particularly in the context of the impact of the pandemic, the inequality impact of the pandemic, and the fact that this was going to be a pandemic of inequality. There were 3 reports, Debbie, 3 reviews, one after the other, in the summer of 2020, disparities reports, as they call them, on what the actual risk factors were. Now, knowing that they knew what those risk factors were, overcrowded housing, the fact that people in low paid and insecure work couldn't stay at home, were forced to go to work, having to travel public transport, not enough financial support for self-isolation, the list goes on. Knowing that, why was there no action?
Well, you said they, and again, I said we're not homogenous. So certainly, those of us who did know, were doing all that we could. We mustn't forget the APPG on coronavirus, which I think has been doing under Layla Moran's chairship. It has been doing a fantastic job around exposing this. But when you say they, we're not.
Yes.
As I say, the single group. Definitely the leaders, our leaders do know. There's no doubt about it. Michael has given presentations to them. I know, I've been there. So, he's done that. But to say all 600 odd MPs, no, that's, and it's about politics. As I say, these are political choices. And this is what we need to, as I say, hold politicians to account over. We say we want to level up and so on. This is the government I'm talking about. I think we're getting a clear understanding 2 years on about what levelling up means. I really don't think they knew, to be honest. And it is about reducing the inequalities that we see, both in terms of socioeconomic groups, but also in terms of the geographical variation, which from a political point of view is so important. But yeah, if I did a random poll, I'm afraid not all MPs would know.
Yes, no, that's a very good point. Martin,
okay.
Shall I pass it back to you?
Thank you very much. So if I can ask both of you, maybe start with Michael and then move to Debbie, just keep in the same order. As I said at the beginning, we are preparing for the forthcoming inquiry announced by the Prime Minister, and also there will be an inquiry in Scotland, and we would like to hope in Northern Ireland and Wales also at some point. And we were wondering if you were on the inquiry panel, and knowing what you do now, what would you say were the biggest mistakes that we made in the United Kingdom during the pandemic? Michael.
Well, what I would do is beat my drum rather than take the sort of broad view of everything. And if you listen to the rhetoric of the government and in this country and many others, it's the vaccination. We've got the vaccination. That's all we needed to do. I've shown, Christina's graphs on the social gradient. I've shown the social gradient in mortality from COVID-19, then took the labels off and showed it to a group of dentists specializing in oral health, then put the labels back on, and its actual dental caries in children shows exactly the same gradient as the COVID-19 gradient. And then I was talking to a group on primary prevention of cardiovascular disease in primary care. So I showed another graph without labels. That was childhood obesity. So if you hang on a minute, vaccination won't prevent childhood obesity. That's diet, exercise, stress. Dental caries, that's diet, fluoride, oral hygiene. We get the same gradient as we get with COVID. And Adam Tooze, in his brilliant book, Shutdown, and I quoted him, he says that silver bullets are the last resorts of autocrats and dictators. He was commenting on the US, but he said, unfortunately, that's where we are. He was thinking about the US, but not far away. We won't address the underlying inequalities in society. We'll just assume we've got a silver bullet, the vaccine, and that's it. And it relates to the health inequalities issue more generally. It's easy to think it's just a matter of a bit of fiddling with access to health care is all that's needed, or a silver bullet like a vaccine. But the inequalities are much more general, and you can't address the impact of the pandemic on the population without addressing the underlying inequalities. I've then gone on to speculate about why we had such poor health pre-pandemic and such disastrous management of the pandemic, and speculated that I think the link works at 4 levels. 1, poor governance and political culture. Second is the increase in social and economic inequalities. Third is the disinvestment in public services. Look what happened in social care and how that contributed to the pandemic, at least in the first wave. And fourth, we weren't very healthy. So my particular approach to the inquiry would be, you've got to deal with the fundamental drivers of inequalities in health. You've got to deal with where we were before, which is the disinvestment from public services, the collaboration in increasing economic and social inequalities, and the poor quality of governance and decision-making.
And indeed, as both you and myself and other colleagues, Lou Ham and Danny Dorling, have shown, we had life expectancy stagnating in the United Kingdom over the last decade. But by drawing attention to it, you get attacked for, running down the country and so on, rather than stimulating anybody to take it seriously. But let me pass on to Debbie and ask you if, would you, I'm sure you would concur with that, but would you add anything to it? What do you think were the big mistakes that we made to put us in the position that we are in with such a high death toll?
One of the, I was out in Erdington yesterday, and I remember I had a conversation with a gentleman on the phone. He said, well, of course, the government have had a really bad time. Nobody could have predicted that there was going to be a pandemic. And of course, we all know that that's not the case. I think there is this sort of alternative reality that is being allowed to play out, unfortunately, not strongly enough challenged, although I try to, and others, Caroline Lucas, another really strong voice in this regard, and Philippa Whitford from the SNP. So there are people across all parties, to be honest, who do try to correct the record, because we had exercise Alice, we had exercise Cygnus, and so on. We weren't prepared. So in terms of emergency preparedness and the understanding about what the different elements of public health are, I mean, there isn't, again, a clear understanding of what this is and how important it is to be properly resourced. So there's all that preparation for emergencies like pandemics that we didn't do, that were ignored, and meant that so many of our medics, for example, lost their lives as a result of inadequate PPE. But as Michael has said, we have not been challenging those elements that are in terms of socioeconomic policy that we know that are driving these inequalities. And we haven't been doing that for decades. Particularly, I will challenge the government and previous governments over the last 12 years, but I have to say my own party didn't do enough around inequalities, and that's why I decided to throw my hat into the ring. And we know that there's overwhelming evidence in terms of what needs to happen, and we've known for a while. So we need to make sure that we target our investment into those areas that need it, and across, as I say, the different socioeconomic policy areas. Is there anything else you want to ask me on that one?
Well, I was just saying, of course, this is famously a country that has had enough of experts. And I think we're hearing from both of you that having an understanding of the issues might actually be helpful when you're dealing with a complex topic. But with that, let me go back to return to Zubaida for the final question.
Well, yes, I mean, I was going to talk to you about what needs to change in health and social policies, and perhaps you could keep that in mind. But I just want to cover one area that we haven't really covered at all, which is at the beginning of the pandemic, what we saw was this, two extraordinary events where we saw the disproportionate impact of the pandemic on Black and ethnic minority groups. And then we, of course, in terms of the US, we saw the sort of the murder of George Floyd and what that meant. And in both those situations, what we saw that when it is essentially that when it comes to inequalities, it means the difference between life and death. In a really harsh way, that's what we saw when we looked at the pandemic and what we saw happening to George Floyd and Black Lives Matter. Now, in the context of that, we saw as the pandemic went on that Black and ethnic minority groups, and as Christina showed, were not only much more likely to be severely ill with COVID, but much more likely to die. And it was different groups in different waves. So in terms of mistakes made in the pandemic, and in terms of moving forward, what can we learn from that so that next time we have a public health crisis, Black and ethnic minority groups, for lots of reasons, are not in the same boat? Well, Debbie, shall we start with you? Oh, sorry, Michael. Let's start with you, Michael.
Sorry. Well, I'm delighted that we now have a race and health observatory. And when I produced my 2020 10 Years On report, I referred to the fact that we don't have good routine data on Black and ethnic minority groups, and that was a problem. And so when ONS brilliantly published the COVID data for Black Caribbean, Black African, Bangladeshi, Pakistani, Indian, and to the extent possible, I like to keep the groups separate, not just say it's all, non-white or whatever. And when ONS published those data, it was really, 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 really shocking. And wow. And given that I kind of acknowledged that there was probably something there, but we didn't have good data, then when we saw the COVID data, my response was structural racism. It was pointed out to me that actually, if you look at all-cause mortality, it was not necessarily the case that the various groups I've just mentioned had higher mortality than the white population. In fact, for some of them, it was lower. So if you're going to talk about structural racism, you've got to have a slightly more nuanced account of why that relates to mental illness, to maternal mortality, to COVID-19, and not necessarily to all causes of death. And I'm all for nuanced accounts. I'm all for better understanding and not just going in with a blunderbuss, which I might have done at the beginning and said it's all structural racism. Well, we need a better understanding. But we do know in the case of COVID, two key factors were one, working in frontline occupations and an overrepresentation of Black and ethnic minority groups. I've now lumped them together, and overcrowded multi-generational households, which were both significant in transmission of risk. So having a better understanding of this, but hopefully what the Race and Health Observatory will achieve is to get better monitoring of the problem so that we're not proceeding in the dark. We will actually get better routine data for the panoply of social and health inequalities as they affect different ethnic groups.
Thank you very much. What about you, Debbie?
No, again, I agree absolutely with everything that that Michael has said, and it will be interested in terms of the analysis that is done when the inquiry finally gets underway, to try and draw out what we can about the causal relationship between structural racism and how this has contributed to this particularly high death toll for Black and Asian minority ethnic communities. I can remember, Zabida, when you were with Runnymede, and we had our own local Oldham Fairness Commission, and we looked at the issue around race and how this was affecting inequalities in education, income, and employment locally. And Runnymede have done some fantastic work around that to show, again, right from early years right through to when you finish your education, if you have And it was something I did also when I worked in public health at the University of Liverpool, and we were looking at the impact of the European employment strategy. What struck me then, and this is going back sort of 16, 17 years now, was that the fact that Asian people, for example, with the same level of qualifications will still be less likely to be in high-paid employment. And this just carries on. It hasn't really changed significantly since, as I say, in 16, 17 years. Can I just mention, because we haven't talked about disabled people, and on so many levels, disabled people, in terms of the impact of austerity on disabled people, have been, I think, hit the hardest out of everybody. Then on top of that, we know that death rates for disabled people they are 6 times more likely to die. I think I'm right in saying that. Yes. And again, there's still this excess death, even when you allow for underlying conditions. There were so many mistakes that were made at the outset. I know from a survey that was done by Greater Manchester Coalition of Disabled People that 2/3 of them weren't included in the official shielding, even though they had severe care needs. They just weren't included. So it was just pot luck. You either stayed at home and tried to keep safe from COVID exposure, or you went out and got your food because you weren't necessarily going to get any help from anybody else. So, this is how we didn't recognise it, and I don't think have done a good job in protecting our disabled people. And still now, disabled people are really scared now that all restrictions are being lifted. And this, again, as we heard from the figures, that we still have a high rate of infections, and we just, that hasn't been considered whatsoever.
No, not at all. There's a lot more to say on that, but we'd like to leave some time for our public questions. So I'm going to thank Michael and Debbie. It's really interesting. I think there's a lot for us to think about, a lot more for us to do. And Martin, back to you.
Thank you very much. And Debbie and Michael, if you can stay for a few more minutes for the questions, it would be great. But of course, we understand that you're both extremely busy. And as Zubaida said, we're now going to those questions. And the first person to ask a question will be Kimberly Chapman. So Kimberly, could I invite you to turn your camera on and ask your question?
Hi, thanks. And I am one of those CEV people who's dropped from the list now. So that's what you were just saying. But my question is exactly on that, is how do we get people, and particularly the press, back to recognizing that the pandemic isn't over? Because those of us who are still having to shield, it's terrifying. And I feel like all we're doing is shouting into the void. And I'd like to know, what can we do? What can we do to highlight that this is not over?
Debbie, I'm going to ask you that because, of course, your role is to represent the people, all of the people. So, and I should say, of course, as you know, my daughter has a particular interest in representation. So I would be interested to hear your view on that.
I'm trying to persuade the APPG for coronavirus to do a special session around inequalities. And we had a session earlier this week, which one of your colleagues, Martin, John Edmonds, was at, and there's a massive consensus from the academics there and the clinicians as well that inequalities are going to continue to widen, and that we need to be monitoring this very closely. So I thought it would be nice for us to do a specific session on that. And then, we do as politicians, but I say we all have a collective responsibility here, Martin, to keep this in the public's mind, and to obviously we need to do that in terms of through the media, all forms of the media, not just the mainstream media, but social media as well. So thank you for all Independent Sage has tried to do on that. So I hope that we will do something on this, just to keep it going, and as we need to do.
So maybe I could, maybe Steve Riker or Susan Mickey might have a view on that. Susan, I think.
Yes, I mean, Kimberly, you asked such an important question about what individuals in your situation can do. And depending on how you define risk, if you define vulnerability as people who are at risk because of their age or because of underlying conditions, it's anything up to a quarter of the population. So we're talking about a lot of people to varying degrees being forced to choose between looking after their health and the health of their loved ones that they share a house with, and being able to go out and go to work and socialize and do all the things that is part of being a human being. In terms of what you can do to change this, I suppose it's just like so many issues, thinking about, are there other groups you can join with? Because for most people, the collective voice is much louder than the individual voice, whether it's in your communities, whether it's people in similar situations to yourself, whether it's lobbying MPs or other people who can be representative. But I think it's incredibly important to find ways of trying one's best, because, when you look at history and when you look at social change, it actually is the cumulative effect of lots of us sort of small people, if you like, all doing things and saying things in a similar direction. So I think the most important thing is not to feel disempowered. I know it's really difficult in the current situation to feel like that, but really try and find like-minded people to work with to try and get voices heard. And I think if we can just all do that, keep doing that, at some point it will get to a level of noise, or those people who are trying to ignore it will be forced to ignore it, that some change will happen.
Great. Steve Riker, do you want to comment on that? Have you got thoughts on that?
Let me just make one point. Obviously, right now, for anything to break into the news, given what's going on with the war in Ukraine, is going to be extremely difficult. And I think the media and many people do have a sense that that COVID is yesterday's news. The problem is that if you treat it as yesterday's news, it will be tomorrow's news, and it will come back to haunt us. But I suppose if I can just use one example. On Holocaust Memorial Day this year, the director of the Holocaust Museum at Auschwitz said the greatest message of the Holocaust for today is for people not to be indifferent. And if you subscribe to the site of the Auschwitz Museum on Twitter, every day they put out a picture of somebody who was murdered at Auschwitz. And the point is to turn a statistic into a face. We all know that old Stalin quote of one death is a tragedy and a million deaths is a statistic. Well, we need to turn those statistics into stories, and we need to show the faces and tell those stories. So I think it's really important that we go away from the abstraction, what we all know about the massive toll on disabled people, on vulnerable people, and we start telling stories, and we get those stories into our social media, and we get those stories into the press, because I think it's a remarkably powerful way of bringing home those realities and trying to challenge that indifference, which has always been the curse and has always been the factor which has allowed great inequalities and great forms of oppression to endure. So we'll try and spread the stories, but clearly you can help us by telling those stories, which we can then spread.
And I'd just like to reiterate Steve's comment about that Twitter account from Auschwitz, which is incredibly powerful, and I think is a daily reminder to us all of man's inhumanity to man. So, Kimberly, thank you very much indeed. And I'm now going to ask Dr. Sally Witcher to ask her question again. Sally, if you could put your camera on.
Hello, can you hear me?
We can, thank you.
Thank you very much. Yes, I'm also a disabled person. I've worked for 30 years in the equality field. I have barely been out my door in 2 years. But I'm not made vulnerable by my clinical condition. I'm made vulnerable by the failure to control infection rates and failure on the part of government. So we need to rethink vulnerability, basically. It's not a good word. My question, and there's so much I want to say, but I will focus on the questions, that's what I'm here to do, is how has COVID not just supercharged pre-existing inequalities, but created new forms of inequality and new groups who experience it. But was it COVID that was responsible or government responses to it? And in either case, do those inequalities remain inevitable? If so, why? Thank you.
I think, Michael, this is very much a question for you. So was it COVID responsible or the government responses that were responsible?
So thank you very much for that question. And I very much agree with the distinction you made between the pandemic and the response to the pandemic. The pandemic would have affected people unequally, no doubt about it. We know that. That's any major external shock does that. I quoted early on in the pandemic the hurricane in Puerto Rico, and the fatalities vary by socioeconomic position. Poorer households had higher fatality rate than middle income, who had higher fatality rate than high income. So the troubles in Northern Ireland showed the same social gradient. The people who succumbed, who were killed, rich people don't get killed in those things. It's poor people who get killed. So it was utterly predictable that the pandemic would increase inequalities. But then the government response could have done something about it, but it didn't. It actually increased the inequalities. And just to take one, I was going to say minor, it's not minor, it's crucial, but just to take one issue. You're infected, you should stay home and be isolated. And what does that mean in terms of your personal finances? Well, if you don't, there was a point Andy Burnham made, in Greater Manchester, if you don't support people economically to stay home, either they'll have to have resort to food banks or they won't come forward and be tested. Because, do you want your children to starve if you test positive? Well, that's part of the response that actually magnifies the inequalities. But I want to take the opportunity. I'm not a harbinger of doom. I'm not depressed. I look at the evidence and I report the bad news. But we did this report for Greater Manchester. We're working in Cheshire and Merseyside. We're working in Lancashire and South Cumbria. And then North Cumbria said, what about us? We want to join. So it's Lancashire and Cumbria now. And the community groups that are making their voices heard, the commitment of local government. And what's interesting, and Debbie will know this, what's interesting, when I hear local councillors talk, I can't tell which party they're from when they talk about these issues. I'm sure others can, but I'm exaggerating only slightly. But the point being, what goes on in Westminster is not representative of what's going on in the country at large. And local government, voluntary and community sector, integrated care services, universities, police, fire and rescue services, local businesses, and communities. I was contacted by a group called the People's Powerhouse. They set themselves up across the north in opposition to, maybe the so-called Northern Powerhouse. They said, we are the People's Powerhouse. We represent the people. And that's really, really, really encouraging that there's a lot of interest. And to come back to your earlier question, Martin, are people listening in Westminster? And I was, it depends what you mean. But they are listening at local and regional level. They are listening in cities and towns all across the country and in communities. And that's really encouraging.
Debbie, do you want to add something to that?
I do, very briefly, if I may. Thank you so much for your questions, Sally. I also think that there are things that we can still do. I think Michael's point about how devolved mayoral communities and so on can have more control and are able to do more in terms of the budgets that they have. But I also think we've tended to focus around income and wealth. I also think we need to look at how we can empower communities as well. And I know, Martin, your daughter was very much part of the Climate Assembly. I would like to see more local-based assemblies, citizens' assemblies, which I think would really give people the opportunity to have some control over the decisions within their communities. I think that would make a huge amount of difference. I don't think everybody in Parliament would agree with me there, but I really do believe that this is an important way forward. And linked to that, there's also some work going on in terms of how communities can be involved in how their public money is spent as well, and a real way to, as I say, give people some control. We know power, status, and so on hierarchies is very important in terms of how we perceive ourselves, but also in terms of impacting on inequalities. And I really do think that these are important ways forward.
Great, thanks very much. Any other comments from any of the other members of Independence Age? If not, I think we just have time for one more question, and it is from Leslie Gardner, who is a primary school head. How do I protect clinically extremely vulnerable staff if there is no isolation period and no testing, particularly as our population is not yet vaccinated? Maybe Danny, I think, or Steve Griffiths. Maybe Danny, we could start with you.
Well, I'm not sure if I'm the right person. We might need Helen on board as well. Because,
or Helen, yeah.
Because I don't think, we have a strategy. We're told that the answer is to turn to GPs who will have a magic answer. And brilliant as our GPs are, I don't know if they do have a magic wand. So it's an unsatisfactory work in progress. So I'm going to try Helen and then Steve, I think.
Okay, Helen, over to you, because I know that a lot of people are saying they're having real challenges getting children vaccinated at the minute.
Yes, and I know we still haven't started our vaccination program here for even the clinically extremely vulnerable may just have started. The main bulk of children won't be being vaccinated, I think, until April is the plan. And it's really difficult. I mean, if as a GP of patients who are extremely vulnerable, what can I say to members of staff? I mean, I absolutely see the head teacher's got enormous problems. And as the doctor of somebody who's a teacher who says, well, what should I do? Should I sign them off sick? I mean, could I sign them off too vulnerable to go to work? Because it will be a threat to their health to go into an environment where there are lots and lots and lots of infected people who, I mean, they want to be there, they want to be teaching the children, but actually, is it sensible for them to be so? And if you're not able to have the mitigations, I mean, there are mitigations to do with ventilation and to do with air filtrations, which can help. But if you've got 30 kids in a room and no masks and no bubbles and all of the other mitigations that we've talked about again and again, I think I'd have great difficulty as a clinician saying, you're fine, just go to work, you'll be okay. Because I don't think that's true. I don't have a solution, because it's not actually a soluble situation if we have made this decision, or the government's made a decision, that it's over and we're not doing anything anymore.
Okay, thanks very much. I'm just going to squeeze in one very final question, but I'll probably not give an answer to it, because it was one that came in from Twitter, which is, how has corruption affected so much the mishandled contact tracing, the late lockdowns and early reopenings due to short-sighted business interest, PPE, etc. And I just want to flag that one up, because I think it is something that we will come back to. It's something that some of us, myself included, do quite a lot of work on corruption. We're hoping to have a Lancet commission coming up on that in the near future. And but it's, I think, too big a topic to address in the final few seconds. And well, we are going to have to wrap it up there. And I'd like to thank very much our special guests, Debbie and Michael, I think we have, I said earlier, we're a country that has had enough of experts, but we're a group that has not had enough of experts. And it's great, obviously, to have fellow academics. And also, I think, and we're not party political here, but it's great to have MPs who are experts in their field as well, and who bring that accumulated expertise. So thank you both very much for that, and for your insights, and for contributing your time, because we know that you're both very busy. I'd like to thank all my colleagues in Independent Sage, and please continue to send your questions to us, and we will see you next week. Thank you all very much indeed.
Thanks. Bye-bye.
Bye.